It's my pleasure to introduce Dr. Patrick Reeves. Dr. Reeves is a quadruple board certified pediatric gastroenterologist, general pediatrician, obesity medicine specialist, and clinical informatics physician with an advanced care in management of children with medical complexity, tube feeding needs, and disorders of gut-brain interaction. He's an associate professor of pediatrics at the Long School of Medicine at UT Health, San Antonio, Texas, and the Uniformed Services University of the Health Sciences in Bethesda, Maryland. He is also an associate professor of military medicine at Texas A&M University Health Science Center in College Station, Texas. Dr. Reeves's specific niche research focus over the last 10 years has been the intersection of patient education and the management of children and young adults with medical complexity. Dr. Reeves is the CEO of his consulting firm, Wild Child Medicine. He has pioneered a new mobile health technology called Clinical Action Plans, which provide automated clinical decision support to medical teams and serve as low health literacy care plans for the home management of patients with chronic needs. So with that, I turn it over to you, Dr. Reeves.
Thanks so much, Jocelyn. And good morning, everybody. Thanks so much for joining us today. I can't wait to get started on some of this great education so that we can help better serve all of your patients. So getting to the nitty gritty, we've got a lot to unpack today. Today, we're going to focus on diet, microbiome, the gut-brain axis, and practical use of enzyme therapies for that. As always, there's a conflict of interest slide, and I have no financially relevant relationships to disclose, and Jocelyn already hit the big points. We are, of course, going to talk about some supplements today. Those are regulated by the FDA as dietary supplements, but not as medications. So it's very important to keep that in mind as we proceed through this talk. And Jocelyn already did a great job telling you a little bit about me, but I'm a native Texan and currently practice in San Antonio, Texas. And my fun fact is that I'm a carpenter. I like to build stuff on the weekends. That's my family and kids you can see there, and they were instrumental. We have our own chicken coop at home, and we built everything in the backyard that our 7 chickens live in now. So we have 3 defined learning objectives for today. The first is so that we can discuss the role of the microbiome, how it's supposed to function at baseline, but how disturbance of that microbiome diversity leads to some of these visceral hyperalgesia and other clinical symptoms that patients complain of for the gastrointestinal tract. We're going to identify some common high FODMAP foods that can trigger these symptoms in the midst of inflammation or in the absence of inflammation, but understand the mechanisms by which we can use FODMAPs to better care for our patients. And finally, we're going to discuss not just how enzyme-based therapies can be integrated, but the practical solutions to do that, helping you to get to that second layer underneath that really where the rubber meets the road, how to help your patients. So going from just figuring out what they need to when they have that first misstep, how to help them correct it and get back on a course to healing. We really do need to start, though, with disease classification and epidemiology. And this starts with terminology. And at the top, you can see the older term that most of us are pretty familiar with, which is functional gastrointestinal disorders. Several years ago, we retrofitted this to disorders of gut-brain interaction, trying to be more humanistic in our approach. And you can see the breakdown of diagnoses, this just being a small subset of what's included in that greater umbrella for disorders of gut-brain interaction. And as you can see, irritable bowel syndrome, functional dyspepsia, aerophagia, functional constipation, many things that you are used to encountering with your patients are all in a family of diagnoses with significant overlap and age predispositions. But we're going to focus primarily on defining the differences between children and adults. It's important to recognize that up to 40% of the global population carries some disorder of gut-brain interaction, chronic diagnoses at one point in their life, and this includes both children and adults. When we break that down, it's a little bit less common globally for children to have a disorder of gut-brain interaction, but functional abdominal pain disorders and irritable bowel syndrome are going to be some of the most common types, with this beginning in school-age children. Conversely, this is going to be more common in adults, usually with symptoms onsetting in the young adulthood period before age 30, but it has a significant impact on their life, especially quality of life, losing work productivity, and generating a significant healthcare utilization cost. If we really focus in where I think the rubber meets the road, it is on the management of irritable bowel syndrome. And again, globally, this is a single diagnosis that we're using out of that entire hat for disorders gut-brain interaction, somewhere around 10% of the population, and it being the most commonly diagnosed disorder of gut-brain interaction. Certainly, Western countries more prevalent to have this, but it is a global phenomenon for sure. Late 20s and early 40s are going to be the two peaks of this, and so it will be very common that you encounter these patients in the primary care clinic, in the dietary clinic, gastroenterology clinic, or even in your multidisciplinary clinics. It's a little bit more common in women than men at a 2-to-1 ratio, and certainly important to recognize that irritable bowel syndrome, even being one of dozens of the DGBI diagnoses, has its own phenotypic spectrum, sometimes with constipation, sometimes with diarrhea, and others with a mix of the two in between. And there are some gender differences in pediatrics, but for the most part, it looks to be about equal. Okay, we had to get that all out of the way. I was telling Jocelyn at the beginning that that is like the most boring part. And I'm excited to talk to you about hopefully what's going to be some practice changing knowledge moving forward. Pathophysiology and understanding disorders of gut-brain interaction and the impact on microbiome is key. And you can think about it from both that top-down model on the left and the bottom-up model on the right. If we look at top-down, there are some exteroceptive stress, psychologic factors, and even early life events that can lead to disorders of gut-brain interaction. There are things that have been associated with a parent who has been injured, even research in the military world showing that children of parents who go on combat deployment and return injured are more likely to be diagnosed with irritable bowel syndrome. That changes the function of different things in our body. Things like the autonomic nervous system, which is supposed to help regulate vascular tone and cerebral perfusion, our hypothalamic pituitary axis, and our hormone secretion. All of these things get altered by these stressful events, which can enhance gut sensitivity, be associated with, or even cause inflammation, and change the gut integrity by increasing permeability. On the other side, that bottom up approach kind of can be whether the chicken came before the egg, really. The enhanced sensory perception and processing that occurs in the midst of irritable bowel syndrome can be associated with decreased coping skills that sensitizes spinal afferents and leads to significant sensitivity to any input that's brought on and changes that efferent output to the rest of the systemic circulation. This interoceptive stress can be the cause of a chain reaction of things like gastrointestinal infections, different causes of gut distension, be that infection or obstruction downstream, or other things like we'll get into small intestine bacterial overgrowth. And all of the time, we're looking to determine if dietary factors and even food allergies are both the cause or the complication of this diagnosis. One of the biggest things that you probably have already encountered for patients is the common finding of chronic pain. And again, it goes back to central sensitization. That stress, especially impacting the amygdala, leads to a chain reaction of hormone cascade from the hypothalamus all the way down with cortisol. And that cortisol overload can also change the way that our peripheral sensitization occurs, amounting to significant visceral hypersensitivity and an altered, really decreased threshold of pain. So if you or I were to get a paper cut, we might look at it, say, ow, that hurts, but move on with life. That same paper cut, as a metaphor, could be quite debilitating for somebody with irritable bowel syndrome who is in need of our help. At the same time, we know that there are things acting centrally in the brain that are changing the way that our nerves, our blood vessels, and our digestive capacity works on a day-to-day basis. There is also that microbiome gut-brain axis connection, even in the outset of the in utero state and when babies are finally born, that dysbiosis that can result from the early use of antibiotics and frequent gastrointestinal infections. As a pediatric gastroenterologist, I see this for kids who unfortunately are at daycare all the time. Early development of allergies and even motility disorders all change the way that the microbiome exists in a child's gut. And it is that vulnerable state that can predispose them, if they have triggering events, to a negative proliferation that leads to more bad guys than good guys in the microbiome and manifests as this central hypervigilance, pain symptoms, and so forth that we can see. And so the important thing to bear in mind is that there are some rumors, I guess, that talk about how maybe babies don't experience the same pain as adults, that babies, because they're only being fed by breast milk or even formula, have a different exposure risk for microbiome changes. I would say that just like we are concerned about infants who have not been fully vaccinated to have serious life-threatening infections, the same holds true that they are more vulnerable than adults to disturbances in their microbiome, which is why modulating their diet can be so key on the path for healing. As they grow older into school age children, when we start to see some of those first signs of psychological distress, be that depression, anxiety, or even stress, it is their response to those exposures that can cause many different changes, both psychologically and digestively in their small intestine and manifest as this functional abdominal pain disorder. And so when we get right down to it, to the nitty gritty at the microscopic level, I want you to envision that we are in the midst of the duodenum of the small intestine. The duodenum is where we do the majority of our digestion, and it is the tips of those microvilli in the intestine. They're going to hold on to these enzymes that are so key. We have lactase, we have sucrase isomaltase, maltase glucoamylase, and of course, aminopeptidases. But we're going to focus on the top three for now. It is the breakdown of these carbohydrates that is associated with a significant amount of gas fermentation and those metabolites that can actually breed some of these negative symptoms that children and adult patients experience. If your lactase enzyme ability to be exposed to these carbohydrates is compromised, you will lack the ability to break lactose down into glucose and galactose. Similarly, it is going to be the disruption of that available enzyme to the food that is coming across that brush border that causes some of these symptoms. And focusing in on the carbohydrates is key because while there are ways that we can modulate a protein diet, the aminopeptidases primarily are going to be involved in a different type, an inflammatory eosinophilic type of GI disease. And so it is for those reasons that we'll tend to again give peptide formulas or even elemental amino acid based formulas. So I personally have seen for the last several years that it is the way that we change diet and really attack carbohydrates that can alter the absorptive capacity of our gut, replenish the gut integrity, decrease permeability, and enhance the quality of life of our patients. And so we've talked a lot about brain, hormones, inflammation, but how does that all actually work? And if we were to use this proposed mechanism, we would see that visceral pain is absolutely associated with exposure to high FODMAPs and irritable bowel syndrome. We have many studies that have clearly laid out this correlation. And when you have high FODMAPs taken in, that's your fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, images here in the food that you can see, First, it leads to greater fluid secretion, both in the stomach, but especially in the small intestine. It leads to greater gas fermentation, causing distension and bloating. And as a gastroenterologist, I will tell you the greatest amount of pain episodes that my patients experience tends to be the gas and bloating pains. It's not the obstructive pains of functional constipation with the fecal impaction in the colon. It's not the pain from transmural inflammation from Crohn's disease. It is gas pains from the distension caused by exposure to high FODMAPs in a gut that was predisposed to triggering that afferent nociceptive process. And so when our gut is actually exposed to these high FODMAP products and it has a difficult time completing the digestive process, this alters nerve signaling. The visceral nerves will respond to both the stretch and the pressure from the gaseous distension and have a release of neurotransmitters, which are then transported back to the brain for you to perceive those signals as pain. And again, what we have been able to demonstrate in different animal models and then in small human case series is that there is a heightened sensitivity wherein your gut releases those neurotransmitters at a lower stretch, at a lower pressure compared to controls in the setting of irritable bowel syndrome or in the setting of high FODMAP food exposure. And so that is how that lower stretch potential still leads to release of neurotransmitters, causing the effect of pain experienced in the brain. I'm sure the crowd is familiar with FODMAPs, but it's important to still look at this. And there is certainly a spectrum from low to high FODMAPs. And this is just one image that I like to show some families, and especially recognizing that some foods might be higher in FODMAPs just based on their age and really the ripeness of it. And so for me, it is a visual phenomena and an education that we have to give to our patients because specifically things that certain cultures really enjoy including in their diet might be something that causes more symptoms. I think many American households like to use whole grain pasta, and that specifically, especially the gluten containing products in there, can be associated with some very significant and negative symptoms. I want to take a quick side quest with you here and talk about the difference between irritable bowel syndrome and other causes of intestinal inflammation that might cause disruption of those enzyme capacities that we talked about in the small intestine microvilli. Specifically, one of the more common conditions that your patients may experience is small intestine bacterial overgrowth. As everyone probably already knows, we have a microbiome in the small intestine, even after exposure to antibiotics, whereas some people have thrown around the idea that we've wiped out the microbiome. It's probably a little bit different than that. It's probably like getting a sunburn, where in your sunburn, you have changed sort of the skin cells a little bit. We're rehealing, we're replenishing, and we don't actually wipe out the bacteria after exposure to infections or antibiotics. Conversely, what does happen is that some of the bacteria, which we tend to think of as good bacteria, also the populations of bad bacteria, because you need the yin and the yang for appropriate humoral response of immunity in the small intestine. Those combinations get thrown out of balance. They're thrown out of whack. And when that happens, especially with the bacterial overgrowth, you can have significant inactivation and reduction of those enzymes. What can happen is that so-called bad bacteria can lead to significant shearing and cutting of those hair cells, the villi, which then means that your enzymes are not there. They're not present to do their biochemical work and perform digestion on those carbohydrates and proteins, be that the case of aminopeptidases. Similarly, we do have studies that show that the enzymes themselves, because of the inflammation and the changes of pH that occurs in the setting of this bacterial overgrowth, what enzymes are there quickly becomes inactivated. So with the inability to produce the enzymes and with the enzymes that you did have rendered ineffective, we then get this malabsorptive process, which can lead to patients having significant changes in their defecation pattern, typically manifesting as some sort of diarrhea. And so when we think about this, if it's one of the most common causes of inflammation, be that acute inflammation that can have a significant change on the integrity of our small intestine, and we recognize that we need to diagnose this condition, treat it appropriately to get our patient back to good health, what sort of state-of-the-art diagnostics can we offer? And there's really two. One of those is going to come in the form of a breath test. And when we perform that breath test, what we are doing is we are giving patients a significant carbohydrate load, and then they are breathing into a special bag so that we can determine if they have the disaccharidase capacity to appropriately digest those foods. If they do not have that enzyme, then a significant greater volume of protons will be produced. That significantly greater number of hydrogen atoms and protons produced actually leads to a significant decrease in the pH, and we will see that in the breath test. That change in pH, as I mentioned, leads to significant inactivation of some of these enzymes and is associated with the gas and the bacterial fermentation experienced by many of these patients. A lot of them even having not just bloating gas pains, but significant belching and postprandial burping and a great degree of flatulence. As you can see in the bottom right of this figure I created, you should also be aware that patients with significantly altered motility, be that with a history of enteric nervous system dysfunction, so Hirschsprung disease, patients with spina bifida, patients previously exposed to radiation therapy and chemotherapy from cancers. All of these patients fall into a bucket wherein the nerve ending firing of the gastrointestinal tract, when exposed to stimulus like food and calories, can be off. And typically that means being slower than it should. And when the food contents move slower because the smooth muscles of the intestine are ineffective in their push, it means that what should be running like a very clear and beautiful river becomes stagnant and murky like a pond. And that can happen in the setting of disaccharidase deficiency. And that can also be caused by small intestine bacterial overgrowth. So it's something very important to ask about because patients with altered motility should have a higher degree of suspicion to rule in the diagnosis of small intestine bacterial overgrowth compared to the remainder of the normal population. So how do we actually get there? Well, as you can see in this figure I created, we are still living in the small intestine. You've probably seen a theme by this point in the talk. And we can get there with flexible upper endoscopy, and we deploy our through the scope channel forceps, and we'll actually take tissues of the small intestine and send that for analysis to quantify the presence of different disaccharidase activity levels. And you can see those normative values placed there for lactase, sucrose, isomaltase, maltase, and trilase. It is very important to recognize that when you are performing this, we should have one sample, one region of the duodenum that is sent for histology to see if there's inflammation to help us potentially rule in the risk for small intestine bacterial overgrowth, maybe by sending a small tissue sample for culture. And then you should, from a different region, take a sample of the duodenum and send it for this disaccharidase testing and enzyme analysis. But here's the key. Let's say we get this test back and the lactase is zero, the sucrase is zero, everything is zero. That is, quite frankly, a normal finding in the right patient, especially if we think that this short-term disaccharidase deficiency is being caused by an acute infection that the patient has had in the recent past. To give you an idea, viral acute gastroenteritis in school-age children is very common. The stomach bug, like norovirus, it latches onto one kid and then just completely knocks down the entire class sometimes, or takes out the whole football team, is what happened in Houston, Texas when I was back in high school. Be that the case, if we were to perform this gold standard diagnostic testing on those patients, we would probably see for those infected patients who are having significant diarrhea, their lactase might be zero, their sucrase, their maltase, their might also be zero. And that means that we certainly have disaccharidase deficiency, but we would expect those patients, in the absence of other risk factors, to regrow their villi and replenish their enzyme capacity in the next 4 to 8 weeks. Now, in normal settings, really does a great job of replenishing itself. And so we wouldn't expect this to be something like a congenital sucrase isomaltase deficiency or a congenital disaccharidase deficiency. Conversely, you have to make sure you deploy this test in the right patient because this is very common in our patients who are diagnosed with celiac disease. It's very common in our patients diagnosed with small intestine Crohn's disease. And so there are many other reasons to do this patient, and it's an important step in the evaluation of any age patient who's had chronic diarrhea and has been recalcitrant to therapy. And so we talked about the state-of-the-art diagnostics, and I think it's time to move on to treatment, which is going to be my favorite part of the talk. And that treatment really needs to hinge on talking about good evidence-based medicine. And so what does that evidence say for the adults? Well, there's two pieces that are definitely worth taking a screenshot of or downloading these slides later, because these are in even the dot phrases that I use to help guide my care and document appropriately for patients that fall into these categories. First, the American Gastrointestinal Association has a diet clinical update from 2022. And again, this is very adult focused, but it has a specific emphasis on the use of a low FODMAP diet for irritable bowel syndrome, and it calls it the most evidence-based diet intervention available for IBS. It does not specifically list lactase or other enzymes as specific IBS treatment, but we'll unpack that in just a minute. Similarly, the American College of Gastroenterology has a clinical guideline on the management of IBS, which is just about 5 years old at this point. This one is also adult focused, but you see a theme. The guideline specifically recommends a limited trial of a low FODMAP diet to improve global IBS symptoms, global symptoms. So we're talking about not just correcting your pooping pattern to normal. We're not talking about only treating your pain, but not correcting the pooping or the vomiting. Global IBS symptom improvement can be experienced with appropriate challenge of FODMAPs in your diet. The other thing that they talk about is food reactions and the fact that some of these are attributed to IBS may reflect enzyme defects like lactase, sucrase isomaltase. So they specifically in this guideline have discussed the platform for enzyme disruption being at the center and open for treatment for these patients. And so some of these carbohydrate transport issues that we'll talk about modulating are specifically talked about in this guideline. So clearly, two of the largest and most effectual scientific organizations in the land for management of IBS both think that FODMAP is an important topic, and specifically that enzymes may be at the center of treating these patients. Conversely, as a pediatric gastroenterologist, it's very important to me, what does the evidence say for children? And I have a great mentor, Bruno Ciampatazzi, who did one of my favorite studies over a decade ago. It was a double-blind, randomized controlled trial that looked at the use of low FODMAP versus the American diet for children and looking at their abdominal pain frequency and severity. And what that team saw was a significant decrease in pain episodes on the low FODMAP diet, and that there was differences in their microbiome profiles as well, with the SAC-T being the increased profile for responders. Similarly, there have been other randomized control trials that have looked at response rates and pain intensity and so forth, which have been able to shows some different heterogeneous results that summarize into two things. One, it appears that when used appropriately, low FODMAP diet has a very high likelihood of success at home. And two, when used inappropriately and when you fully eliminate FODMAPs for your diet for greater than 6 weeks, there are safety concerns for potential nutritional deficiencies that can be developed. One question that may be in your mind is, okay, so we talked about some potential enzymes. What about other supplements? And I'll put a plug for those that are in there because going at this holistically and really from a functional medicine perspective, I like to put my best foot forward. Certainly, high dose enterically coated peppermint oil has also been shown on a conditional status to improve global IBS symptoms, and also probiotics have been suggested against for global IBS symptoms. And the key here is we could do a whole nother talk on probiotics. We don't yet know enough about the microbiome to know which yin should go with which yang. We don't know which colony forming units are going to be best. We don't know what combination or in what concentration they should be in. So while I think we may get there, the jury is just still out on probiotics at this point in time. Okay. And so getting to the crux of it, clearly we've shown that there is a need for this based on epidemiology. We've gone over the pathophysiology and shown you that at the biochemical level, FODMAPs certainly cause symptoms if they are high FODMAP foods. And we've even shown you that some of the largest gastrointestinal organizations in the world recommend low FODMAP diet or changing the way that we digest food with these enzymes. And so when we break this down, we worry primarily about these food groups that you can see here, like fructans, like polyols, like lactose. And we should, from the first step when we encounter these patients, offer them, I think, a management strategy that is either just dietary and medicines, or some other homeopathic remedy that is available to them. I think at this day and age, we have lots and lots of patients, both pediatric patients with adult caregivers or adults coming to us with needs to help manage irritable bowel syndrome. And the key that we can do is meet those patients where they are, because I think many are in the search for the idea of food as medicine and using dietary modification to manage their symptoms as opposed to just popping a pill to try and make them better. And I think that we have the tools at our disposal to meet that need and meet that request. Before we get there, I did want to again make that one plug is that in pediatrics, the Chimpatazi 2015 trial remains the most rigorous trial with objective crossover data design that shows that low FODMAPs is a safe option for kids. But really, the systematic reviews are insufficient to fully universally recommend this in all pediatric patients. But I would challenge you that in a patient who is growing well, and has no other risk factors such as inflammatory bowel disease, I would challenge you to say, why not go and modulate this patient's FODMAPs to see if I can make them feel better? And really, guidelines have treated these enzymes as targeted therapy for the right diagnosis and not necessarily for just IBS itself. Now, this is maybe a breather for me, but enzymes can mean many, many different things, team. And I was in Washington, D.C. years ago and was taking call for a patient who had a food bolus impaction. It was a big piece of steak stuck in the esophagus. And the question of enzymes came up in the emergency department, and that emergency department provider asked if they could run down to the kitchen and get some meat tenderizer and have the patient swallow those enzymes to help break down the meat of the steak. And so I just put this up as a public service announcement. Not all enzymes are created equally. Not all enzymes that you can get at Walmart or Target or wherever you do your grocery shopping are going to be safe. And meat tenderizer will absolutely tear through your esophagus tissue and your GI tract just like it tenderizes the steak out on the plate in front of you. So please make sure we're talking about the right enzymes. It's so important that this year the federal government has started a new program by which they're going to be grading hospitals on their ability to communicate with patients, performing the universal precautions approach where we presume low health literacy. And so while some of you may be sitting back and wondering, is he bringing up meat tenderizer? I kid you not, that patients may give you the up and down head nod and tell you, yes, they understand, but it is important to make sure that when you say enzymes, you're helping them select a product that is going to be safe for them, that you're not giving them a global blanket term like enzymes and potentially putting them at risk for taking something that could be very catastrophic for their health. Okay, back to the good stuff, practical strategies for the patient. So I think this comes first with understanding the FODMAP diet. First, we understand that FODMAPs are fermentable carbohydrates and they can be poorly absorbed in the small intestine. This is key. This is an image I would highly recommend that you share with your patients that I've created that I think fits their needs. FODMAPs can increase gas, cause increased fluid secretion, cause fluid shifts across the brush border, and increase that intestinal distension. We showed that in the pathophysiology section, but I think this really sums it up. All of those things, the greater volume of gas, the greater volume of fluid leading to distension is what triggers abdominal pain, gas pain, diarrhea, and even constipation because of those alterations on the enteric nervous system. People with gut-brain interaction disorders like irritable bowel syndrome are more sensitive to these effects, and it's why it's so important to make sure we educate them about FODMAPs. You can see that we put some of the most common things up that people are going to have in their kitchen, even things like dairy-based milk that are highly associated with FODMAPs, and really maybe something else that should be a mainstay of the kitchen is adding some of these over-the-counter enzymes to the cupboard. Now, when we actually get to the use of the low FODMAP diet, you'll find lots of different ways to do this online. Certainly, a lot of these are evidence-based driven, specifically from some of these randomized controlled trials, but I want to educate you on the practical pieces that I try to provide to my patients. First and foremost, there is sort of the all or nothing approach where we remove all high FODMAP foods from the diet for 2 to 3 weeks. That's a lot. It's a lot. This is the one that you're going to see most frequently online for different hospitals and things like that, just basic patient education. And when you do that, you do it for just 2 to 3 weeks, and that's key. In fact, when I'm in clinic, if this is something patients opt for, I look and say, okay, 3 weeks from now is this date. Put the calendar event in your smart device so it tells you today is the end of your trial. If you really were to go twice that long, 6 weeks, you can absolutely develop nutritional deficiencies, and that's absolutely something we want to avoid. What I'll show you in a few slides is actually my preferred method of doing this, wherein we see a list of high FODMAP foods, and on the next column over right next to it, you look at low FODMAP alternatives. And sometimes we can make good headway on these symptoms by having patients select a substitute that may not cause the same symptoms. So again, I think it's an appropriate style, either eliminate everything that is high FODMAP from their diet for 2 to 3 weeks, or figure out the things that are on the high FODMAP list that they are intaking more than once a week and identify those potential triggers through elimination phase of the diet. And again, key is this phase is not fully just this phase is diagnostic. It should hopefully be therapeutic, but I typically tell patients and give them the impression that it didn't take a couple of days to get to the state. It didn't take a couple of weeks. And so it is probably going to be a much longer haul, wherein if we figure out that dairy or gluten is the high FODMAP trigger, then it's going to take several months at minimum to fully heal that small intestine and reset this pain sensitivity point in the brain and be able to reincorporate those foods in the future, if ever. And this is again the safety stop where we talk about long-term exposure to low FODMAPs when we're universally eliminating those high FODMAPs. For pediatric patients, especially, that can lead to poor growth or really just being underweight and having a drop in BMI. And for my purposes, I always worry about the deficiencies in calories and vitamins that would be lacking from this diet because many of the high FODMAP foods are high caloric density and contain significant important vitamins and minerals, things like thiamine, folate, calcium, magnesium, and iron. And so again, the biggest thing that I give my patients is you are not allowed to do this universal FODMAP elimination for greater than 6 weeks. At 3 weeks, you stop, and we are hopefully following up at least virtually, if not face to face, to check in and see how they're doing. In a few slides, we'll also talk about how there is some incredible things developing as far as symptom tracking, evolving from just the simple paper handout that you give them, but really digital diaries that can come up with scores to help change the way we're caring for these patients. Similarly, what I often do on first-time visits with these patients is say, okay, now if we're going to stay on the high FODMAP diet, but you think you know what your triggers are, this is an excellent entry point for some of these enzymes, because specifically, if we're going after gluten, if we're going after dairy and fructans and polyols and some of these others, we have enzymes available over the counter that we have excellent anecdotal evidence to support use for. And that means that we can decrease the bad symptom profile and maintain those same RDIs that are so important, that same caloric need to support growth without developing deficiencies down the line. So I would say for me, this is a capstone slide showing that digestive enzymes can really increase the dietary diversity of foods available to patients with disorders of gut-brain interaction like IBS. They can hopefully start to feel symptom relief while consuming the same foods they normally do. And then, of course, there is a challenge phase, step 3 of the low FODMAP diet, and that's where we reintroduce high FODMAP foods one category at a time, or we're testing each FODMAP group over several days. For me, I prefer that if we've just done a few foods taken away, then we introduce one food back, wait 3 to 5 days, we get good serving of it each day in a row, and we see if those symptoms develop. All the while, it is the tracking of those symptoms that are so key because life gets busy, life gets hectic, and if we don't keep those foods that we've ingested and the times that we did it straight, it can be really difficult to tease out what's really causing our pain or our gas or our diarrhea versus what's not. Taking enzymes is also an important thing here that we'll practically get into in a few slides, because this may also be an opportunity that if you felt for that normal, single cheese pizza that you were having at lunch, if you needed 2 packets or 2 scoops of enzymes, perhaps we could go down to 1 scoop and see if you can still maintain that symptom benefit. So there's different ways that we can go about this, but recognizing that after 3 weeks of the diagnostic phase, step 3 is reintroduction. This is just one food log that I love to use, and I use it for kids because it's cute and it's easy. And you feel free to use this if you want. But again, there's lots of other things that are out there, and some of the newest state-of-the-art symptom management profiles have started to use different algorithmic approaches based on patient inputs to help capture and really inform people what is maybe going on. Different things that are smart devices that you can wear on your wrist and on your finger have really already done this to incorporate for sleep, for activity and things like that. Super important from a universal treatment perspective for irritable bowel syndrome. But really, things like the BellyMD can provide that score to help guide patients for what steps to take in their therapy from a day-to-day basis. What's really important, in my opinion, is tracking the date that we have had these symptoms, tracking all meals and whether those meals contained high FODMAP foods or not, because some meals may just naturally be low FODMAP. Really important for portion size. This is very difficult for kids, especially because if they took 2 bites of macaroni and cheese, it's probably not a full portion size. But if they had a double meat cheeseburger, that's probably significant. And then for me, again, universally speaking, we talk about whether enzymes were taken and really I try to help them more than yes, no. Are we doing 1 packet, 2 packets, or something like that? And then really trying to help patients become self-actualized to the idea of a weekly summary, understanding if they had foods that previously caused symptoms that were now tolerated, or helping keep track of what the worst triggers that they've experienced are. So for me, this is the global list of vital signs that I care about when we're instituting that FODMAP diet change and using enzymes. Some of the practical things to talk about, though, with enzymes is that, of course, you need to breathe, relax, center yourself when we're taking in a meal. If meals are alone or with a group or family and over a table, this is an experience. And so it shouldn't be a stressful one. It shouldn't be a rushed one. So again, the biggest thing we talk to patients about is that by rapidly eating food, maybe shoveling food into their mouths, it can certainly cause symptoms because your GI tract may not be ready to rapidly digest this enormous volume of food, even if it's a single serving. So going through this methodically is very key. Those enzymes can be mixed with food or sprinkled on top. It's almost like adding seasoning. It really should be that easy, with the one caveat: you need to avoid doing this with very, very hot foods. Things that are boiling is certainly something you need to let cool. Something that's greater than 140 degrees Fahrenheit needs to be allowed to cool. Again, sometimes we need more because these enzymes have an absolute quantity. And if the amount of gluten, for instance, that you're taking in is enormous, 1 dose may not be enough. And so what's really important is to help people sort of figure out their DNA of these enzymes to help them experiment during this diagnostic phase of the low FODMAP trial so that we can determine physiologically what dose is going to help them best. In a perfect world, that means that we start to use that symptom log to associate that, oh man, I did 1 scoop or 1 packet with my single cheeseburger, but that was not enough. And then we build that in so that in the future, these patients are not necessarily just coming to you for the management, but they have embraced the concept of self-management. Of course, we need to reinforce thorough chewing, and it's not just so that the enzymes are mixed in. It's also because some of the salivary enzymes that are secreted through the chewing can actually theoretically help improve absorption across that small bowel brush border and get that digestive process started. So if we're swallowing something that's only half chewed, you may not have that initial sort of pre-digestive process optimized. And so going through the chewing process with patients is key. And then you repeat as needed. This might be something you do with every mealtime, or it may be something you only choose to do with dinner. And helping patients understand that whatever is helping their symptoms best is the right plan is key to this full spectrum care. Now, it's a practical takeaway for patients is that things like lactase tablets and other over-the-counter enzymes are FDA-regulated supplements. They are not FDA-approved medications, which is why you're probably not going to see them specifically mentioned in many guidelines from some of these large scientific organizations. It's really the FDA-approved medications that we tend to see. But given how effective FODMAP manipulation can be to help patients with IBS, you've seen that they are very prevalent in some of our guidelines already. Potency can certainly vary by brands, which is why I really just use one brand in this setting for these patients, and it's generally considered safe with minimal side effects. I will tell you my experience has been using them in patients with just irritable bowel syndrome. I've used them in patients with inflammatory bowel disease and superimposed irritable bowel syndrome on top, because you can certainly have both. And I've had significant anecdotal success with my patients. And so for me, if we're thinking FODMAP is the way to go, talking about enzymes to help really liberate these patients is also in that first conversation. Okay, so we have some cases, and I'm going to try and get through these in the next couple of minutes so that we have time for questions. I will summarize everything, but case one is going to be a 14-year-old girl who was previously healthy. She has got some significant chronic cramping. She was initially evaluated by her pediatrician who thought she might be constipated, but with good fiber and appropriate osmotic laxatives, she did not get better. She went to a peds gastroenterologist, and as is common, chronic pain, constipation is better. That gastroenterologist recommended cyproheptadine. This is a real case from about a month ago. This patient's parent expressed concern about starting a medication and wanted to explore other non-pharmacologic options first. Again, child growing well, has some cramping abdominal pain that's been chronic. We've already made sure the pooping is already good, and this parent wants to do a more holistic approach. And so, of course, we should have the conversation about a low FODMAP diet. Now, here's the key to this case. After 2 weeks, there was a little bit of symptom improvement, but the family is reporting the diet is too restrictive and difficult to maintain. Turns out this kid was also a little bit of a picky eater, and it's really hard at school because the child purchases food for lunch at school, and she doesn't like the idea of having to have a different selection than her classmates. So what should we try next? This is the list that I told you about that I share with my families, and it helps us figure out what substitutions might be best for these patients. But again, you can see how we can show all kinds of different things on here, but I use it to figure out, okay, what things are you eating most often that are causing your symptoms? Well, she said that every single day she likes to have wheat, honey, and avocado for breakfast. And if you didn't know what that was going to be, it means she's having avocado toast, which is a staple in South Texas. And so it was very easy, recognized that those were all high FODMAP, recommended some over-the-counter therapy to her, and she actually were reported back a couple of weeks later to be completely symptom-free. So again, it's important to not just start some of this guideline concordant therapy, but to follow up and to see if there's a way that we can make their life even easier. Because now this patient has basically self-actualized to figure out she can eat whatever she wants. She just needs to make sure she uses her enzymes appropriately and adequately for those meal times. This is just another option that if you're wanting to do, this patient had a little bit in the way of regurgitation that was still happening. And so this is my abdominal pain action plan that I share with these patients so that we can make sure we're taking care of them. Deep breathing and diaphragmatic breathing exercises can help with these episodic symptoms, but certainly one packet with meals can be really, really helpful. Case two, it's a college student. And kind of similar story. She had some intermittent abdominal pain, but with really some upper GI tract bloating, some constipation and diarrhea that alternated for the last year, and it worsened as she moved away from home and started college. Her primary care provider diagnosed IBS and did some screening labs. Everything's normal. No anemia, no dietary deficiencies, kids growing well, not losing weight. Everything's good. She tried fiber, tried probiotics, tried some antispasmodic medication, and nothing was helping. And she felt like gluten is a trigger. But this was key when she got to me. This patient loves baking. And a lot of the time we're baking, we're using dairy to help bake, and lactate milk has not helped. And so she really had figured out for herself, made my job easy, that she felt like gluten was a trigger. What was key is the primary care manager had already screened for celiac disease, and the screening was really low risk, not really worth doing an upper endoscopy to look for celiac disease. She was interested in learning how to use diet, stress, and gut-brain interaction knowledge to manage her symptoms. And she said, what should we try next? I don't have celiac disease, but I think gluten's a trigger, but I love gluten. I love baking, and I really don't want to eliminate that. And it's really hard task sometimes because gluten is certainly not necessary for someone to thrive as far as growth is concerned, but it may be very necessary from a psychological perspective to make sure that someone's mind, body, soul, sort of biopsychosocially, that they thrive. So we needed to figure something out. We did our symptom tracker, showed that there were some significant symptoms for about 2 weeks with no enzymes, helping me to confirm exactly what she had said. And then we reviewed that there are lots of non-food sources of gluten, but at the same time, we implemented an enzyme strategy that she was even able to weave into her cooking strategies, and she had significant symptom improvement. So again, a patient with significant gluten triggers who does not have celiac disease benefiting and able to continue that high FODMAP with the appropriate therapy. And finally, case three, this may be one that you guys are familiar with. It's a 35-year-old female who's a mother of four, and she has a long-standing history of irritable bowel syndrome. This is not new, 15 years in the making, recurrent abdominal cramping, bloating, sense of urgency for stools. She's really fatigued because she's a hard-working mom, and she compensates with significant caffeine intake from coffee. She does skip meals from time to time, and she's previously undergone a pretty good workup with an adult gastroenterology team that was totally normal. In fact, she even had disaccharidase testing, and it did show that the enzymes were technically appropriate in quantity based on our normal values. She's tried different dietary modifications, did dairy-free for a month, saw some benefit, but was not maintained when she used regular dairy milk and lactase enzyme. So she's trying to figure out, what can I do? I'm so busy, and so on and so forth. This is not my case. It's a case of a friend of mine. But when you get down to it, it seems silly. But what do you drink with your coffee? Oh, well, I drink coffee with creamer every single day and multiple cups a day. Well, when this patient realized that sometimes IBS symptoms can be enhanced by coffee, but she'd actually tried to go coffee free and that didn't help her. But it was really the high FODMAP in her milk and creamer that was causing these symptoms. And by instituting the enzymes directly into the coffee, she was able to feel better after letting it cool. Apparently was even recommended to do iced coffee for a time. So big key here is that coffee in and of itself is not a high FODMAP, but it can be a non-FODMAP related IBS trigger, but it is typically the additives for coffee containing lactose from milk, flavored syrups that contain fructose polyols and other artificial sweeteners that can certainly cause IBS symptoms, that if that is key to their life and if they're certainly taking in a lot of it, they may benefit from supplementation. And so I'm going to conclude there so that we save some time for questions, that both adult and pediatric disorders of gut-brain interaction have evidence supporting the use of the low FODMAP diet. There are certainly limitations to this diet. You don't want to develop nutritional deficiencies. And to combat that, enzymes can provide a safe over-the-counter option to alter these symptoms. And the key to success is trial and error with state-of-the-art symptom tracking throughout. And with that, I will pause. And Jocelyn, if you'll help open it up to questions, please.
Fantastic. Thank you for such a great presentation, Dr. Reeves. To everyone out there, just want to let you know your CEO certificate is in the chat. If you want to download it, you'll also get an email from me later today or tomorrow with a link to download it as well. I also want to clarify a couple things that Dr. Reeves has mentioned around gluten. Gluten is not a FODMAP, but many providers will kind of mention or reference gluten kind of as a proxy to describe wheat foods. These are all high in fructan, which is a FODMAP. So when we kind of describe gluten in this context, it's often around just gluten-containing foods, which then are FODMAPs and triggering for patients. With that, let's dive into questions. Dr. Reeves, we've got a bunch here asking about the enzymes that you do recommend. So the brands and the types of enzymes. Let us know what you recommend. We've got a lot of questions.
And we're able to talk products?
You're able
Okay.
to mention brands for educational purposes. Yes.
Yeah. Well, and honestly, guys, for educational purposes, FODMAP has been the answer to a lot of patients' prayers here for many years. And I think the biggest thing, honestly, is the individualized packets. The tubs are super helpful, especially if you're going to be at home. You keep it in the cupboard. The scoop is easy, but it's the individualized packets, especially for parents of kids who need this product, who they can put it in their car, put it in the glove compartment, slip it in their pocket, because who knows what they're going to eat when they're ready to eat. and it's an easy access available. So a lot of the other products are not packaged the same way. The other issue that I have with other products, I'm not going to besmirch anybody else, is that I have concerns regarding quality. I have concerns regarding safety, and the same anecdotal evidence to support the effectiveness of those products is certainly not there. As Jocelyn was just talking to me about, and it's super exciting, there is hardcore, real clinical based trials that this product is undergoing so that we can continue to expand the evidence by which these claims are backed up. And the same is just not done for some of these other products. And so I tend to stay away from them. Have I had patients use others in the past? Absolutely. But the first thing I tell them is, I'm not an expert on that product. I only know so much, and I figure out a couple of things that I am most comfortable with. I try and become an expert on that. And so that's what I use because I'm a physician who practices a standard. And that standard means that if you fall under the same bucket, I'm going to personalize to your needs, but that probably means I have a product in mind for you. And for cases like this, FODZyme is the direction I go.
Thank you. Great to hear. Dr. Reeves, we've also got questions just to share the names of the enzymes themselves. So I know you've mentioned lactase a few times. What are the
Oh,
other
sure.
ones potentially for other or FODMAPs?
Like as far as the small intestine villi goes,
Yeah, it's something I'm picturing alpha galactosidase. I know we've got the fructan hydrolase, like any others that you are generally just truly like the non-brand generic names of the enzymes for folks to jot down.
yes, I mean, those are the top three, really. I think the hard part too is recognizing some of the evidence that we have, like for disaccharidase testing and things like that, which not all these enzymes are disaccharidases. Not all the enzymes are the exact same, as Jocelyn appropriately told us a second ago. The hard part for me, guys, is that it is almost impossible to know where to start with on some of these patients. For me, the diagnostic phase of the low FODMAP diet, where we're using the product, is the great equalizer. Because if for some reason we are continuing to develop symptoms despite using the product adequately, that's for me a different vital sign where we have to figure out, oh, this is a patient we weren't thinking about testing before. Maybe we do need to go that direction because, especially for me, that's when your question about are your fatty acids being digested appropriately or proteins being digested appropriately. Most of the time, we're talking about carbs for this, but if those digestive processes are compromised, that's when you probably need to see your friendly neighborhood gastroenterologist for a repeat endoscopy and determine, is there something going on at that brush border, IgE, non-IgE mediated eosinophilic inflammation, more inflammation from infection, IBD, things like that, that might be causing this. So again, I say that the product is great from a therapy, but please don't underestimate its ability to be used as a diagnostic tool as well.
Great, really, really fascinating. Thank you for clarifying that. We've got a question. Is there a timeline for enzyme use? Any downside to using them long term?
I haven't appreciated that, no. And I think the best anecdotal evidence I can give you is in college students because I will tend to hold on to some of these pediatric patients until they get their first job or they're off parents' insurance, that sort of thing. And so we have lots of people who are in college doing this product for 4+ years, the most stressful time of their lives, most of them. They stay on it, they get to a good place, and when that point of self-actualization is reached, and they're like, okay, I want to trial off. I say, let's do it. Um, I can tell you with no doubt, I have not seen any untoward effects from long-term exposure. And it would be the same, I think, for there should not be long-term negative effects from eliminating gluten from your diet. If you want to go gluten-free so that you can avoid the fructan FODMAP in that instance, you should be able to execute that safely, especially with a good RDN, without causing deficiencies in your life. But every patient is different. For me, my core involves follow-up, be that face-to-face or virtual. And so if they're doing great for months and months, all of a sudden we follow up and the sky is falling and things are terrible, well, then we have to adjust fire. But I have not had that instance, at least with the use of some of these over-the-counter enzymes.
Thank you. Great clarifications. Here, this will be our last question, but while we have you, and you're, of course, an expert in the pediatric space, the question is, can you describe the role of family members in tracking symptoms and enzyme log if children are in daycare or schools with other caregivers? Any comment on how we can best approach this from tracking, but I figure also just adherence and general kind of usage recommendations that
Yeah.
you're giving?
Thank you to whoever asked the question. That's been my research the last decade. So if you figure it out, let me know. We'll share the Nobel Prize. It's going to be great. But tracking is for me the most important thing of all because we have an ever-changing microbiome. We have an ever-growing child, developing child, things like that. So what worked in 2025 may not work in 2026. Tracking is key. My action plan that I showed you has the symptom log on the back side. And so we print that out or we use it digitally and we're tracking throughout. Again, there are other products out there like BellyMD that allow you to have a short screen. So you answer a report, click, click, click on your smart device and then it kind of develops your belly score and you can use that to figure out if you're feeling good, if you're feeling bad. It's just like some of these scores you can get from the smartwatch, the rings, so on and so forth. So I think that's key because what I think the next forefront is sort of automatic tracking with minimal effort for data input. That's where we're going here in the very near future, especially with BellyMD. Conversely, the adherence thing is very hard, and that's why I developed a clinical action plan just to revolve around this diagnosis. The key for pediatrics, especially school age kiddos, is that there's federal law to support you putting this in to their IEP, which is an individualized education plan. And that means that this plan I give my patients is a doctor's note. It's signed. It goes to the academic team, and they recognize that, oh, okay, so whatever we figured out, the kid might need to come after, I don't know, after ice cream and cupcakes were served in class for a birthday party. They know that they need to come to the nurse and get their single serving of enzymes, things like that. So everyone's just a little bit different, but I will say that that practical strategy is facilitated using a clinical action plan, and it just warrants dialogue between someone from the medical team, the parent, and the school.
Thank you so much. Very fascinating. And I hope the research is going well. We're all eager to hear what you learn. With that, I want to thank you for coming on. Thank you to everyone out there for your interest in this topic.